Hello friends, so I'll be giving a overview on this topic, recent advances in cardiac critical care. So I was asked to give this talk in conference in Calcutta, the Manipal Dakuria one organized by Dr. Subhash Todi sir. So this happened on 21st Feb 2025. So when this topic was given, obviously in the previous video, many of my listeners would have heard about all the journal review that happened in 2024 related to cardiology and hemodynamics. So this topic followed that particular talk. So I had to just cover about what is new thing that has possibly happened in cardiac critical care. Quite valuable for all the trainees. So I've divided this talk into three sections. So one is what is new in acute coronary syndrome. The second component is what is now processes in cardiac critical care and in cardiogenic shock. So these are the four entities. So I'll just talk through the newer aspects that has evolved in cardiac critical care. So when you we'll just look into ACS, what is new. Sorry, I think it's with a moment of slides. So they have put up this acronym called ACS. So acute coronary syndrome, as you know, is abnormal ECG as an acronym patient with regards to whether patient is stable or unstable. And when you look at the whole pathophysiology of atherosclerosis, so there is a plaque rupture and there is this red blood cells and platelets that tend to aggregate and forms a sort of a clot that you see. And this clot occludes and then they'll have a staining. So this is the pathophysiological understanding that your primary nidus for the clot formation or the plaque is the plaque rupture. So there is a lot of inflammation that happens, and the size of the plaque and the inflammation and the instability of the plaque is what determines the sort of a ACS that tends to happen. So when you look at the update, they have divided ACS, I'm sure this is pre-existing, into unstable angina, where in unstable angina, we say when there is no necrosis of the myocardium, and we stay non-ST elevation MI when there is a partial necrosis of the myocardium. As you see here, there is a white thing. This is the partial necrosis of myocardium that tends to happen in end-stage, non-ST elevation MI. If you look at ST elevation MI, then there is a transmural necrosis or greater thickness of the myocardium that gets involved and that gets devitalized and necrosed is what happens typically in ST elevation MI. So these are the three distinct sort of a categorization of ACS that we tend to see. So what is new in ACS? So the new guidelines that has come in place is mainly from 2023 European guidelines. The HA guidelines has come in 2022. So we look into what has changed from earlier guidelines to the latest one that is meant to be adopted, which is 2023. So the whole focus is on going more invasive with regards to ACS management, and there is a little downpedaling and de-emphasis on medical management. So there is more aggressiveness or proactiveness that is happening with invasive. So it has to be invasive management. If it is ST elevation MI, I'm sure all of us know that percutaneous intervention by placing a stent is the way to go. But for some reason, if there is no facility available for percutaneous intervention, then there has to be there has to be thrombolysis that has to happen to lyse the clot, and then after that also they need to be subjected to the percutaneous intervention. And if it is very high risk, even non-ST elevation MI, acute coronary, if you recall, maybe in my training days, it used to be more medical management. Now, even in these settings, it is more of percutaneous intervention, even in high risk non-ST elevation ACS. And in high risk non-ST elevation ACS, the suggestion or recommendation is angiographic intervention or evaluation of the severity of the problem has to be ascertained within 24 hours. There should not be delay in angiographic evaluation of the extent of involvement of the vessel occlusion that may have happened. And after this, the whole approach is anti-thrombotic therapy. When you talk about anti-thrombotic therapy, you can divide into two major categories: antiplatelets and anticoagulation therapy. So when we talk about antiplatelets, the 2023 European guidelines suggest more emphasis on G2PY inhibitors as opposed to the aspirin. So that is a new change that has happened. So there is more emphasis on continuation of G2P1 inhibitor as opposed to the aspirin. So GP2Y12 inhibitor is more emphasized. In anticoagulation, obviously the choice would be predominantly low molecular weight heparin. There is some contraindication, then unfractionated heparin or fondaparinux or bivalirudin. And even after this, the revascularization has to be thought of if there has been thrombolysis that has happened with anticoagulation and antiplatelet. Even then, revascularization has to be thought of based on the clinical situation, comorbidities, and disease complexity. And after that, one has to determine whether the vessels are suitable for percutaneous intervention. If it is not suitable for percutaneous intervention, then surgical sort of a revascularization with bypass surgery has to be thought of. And aim is to always complete revascularization of the vessels should be the sort of a goal that needs to be set in. And in the newer guidelines, emphasize on the need for subjecting adjunctive tests like endovascular ultrasound. So intravascular IVUS, which we say, intravascular ultrasound is to determine the feasibility of various other modalities to attain complete revascularization like rotablation, so on and so forth, by ascertaining the intima. As you see in intravascular ultrasound, one would see the feasibility of percutaneous intervention by ascertaining the intima, media, and adventitia of the blood vessels. So this is also something that has been emphasized. And when you look at the ACS spectrum, so the type of patients that tend to come have a spectrum. It's not like one garden variety they come. So sometimes they can be asymptomatic. Sometimes they could have increasing chest pain. And third category is persistent chest pain. And the typical ones that we tend to see in ICU is someone who comes with cardiogenic shock or heart failure. So that's the spectrum we tend to see, or cardiac arrest. So, and even in these five sort of a clinical dimensions, the investigative modalities also can be quite fluidic, like ECGs in asymptomatic and increasing chest pain. It can be normal to some non-specific ST depressions. When there is persistent chest pain or cardiogenic shock or heart failure, they may come with quite evident sort of an ST elevation, or they can come with VT or some sort of a tachyarrhythmias, VT or with VF, so on and so forth. So there are even the type of investigations corroborates with the sort of a clinical picture. And even the investigative modalities can be quite fluidic. In ST elevation, acute coronary syndrome, the high sensitivity cardiac troponin not necessarily may be elevated, and this can be seen in unstable angina. But typically, the type of patients we see where there is a STEMI, where they come with cardiogenic shock, there is a rise and fall of these cardiac enzymes. And this spectrum can be anywhere between non-STEMI to STEMI. So there are a lot of variations with regards to the ECG findings, corroborating with the clinical context, and corroborating rise in the cardiac enzymes also can be quite variable based on the spectrum of clinical presentation is what we need to keep in mind. So let us look into the revised recommendations that has come in acute coronary syndrome from 2023. We are sitting in 2025. So this is what has come as a recommendation. So if patient has no recurrence chest pain, and ECG is normal and cardiac troponin is normal, but there is still a strong clinical index of suspicion of ACS remains in the clinician, then the suggestion in 2017 guidelines. So when I say one and B, one is a strong recommendation, B is moderate level of evidence. When I say two, it is a moderate level of suggestion, or when I say two, and A is a good level of evidence, B is moderate level of evidence. So the 2017 suggests that some sort of a non-invasive investigative modalities like MRI or radionuclide imaging has to be done to ascertain the risk of any myocardial ischemia was recommended. Even in 2023, the 2A, when I say 2A, there is a suggestion. This is not a strong recommendation, but a good level of evidence that cardiac MRI or non-invasive sort of a modality, like a radionuclide technetium scan, so on and so forth, has to be thought of in determining the myocardial ischemia, is what has been suggested in 2023. If it is a non-ST elevation MI with a new ongoing ECG changes or transient ST elevation MI, then 2017 strong recommendation, good level of evidence was early invasive strategy within 24 hours was recommended. But now in 2023, that has little downpedaled, but early invasive strategy has to be done within 24 hours should be considered. It's a strong sort of a good level of evidence with a moderate recommendation has been suggested. So this is there is some change with regards to the level of suggestion, but pretty much the philosophy remains simple, that it has to be early invasive strategy within 24 hours. And P2Y12 inhibitors, which is prasugrel, ticagrelor, or clopidogrel, has to be administered prior to the percutaneous intervention and to be continued for 12 months was suggested in 2017. It was recommended. When I say one, it is a strong recommendation with a good level of evidence. And that pretty much remains the same even in 2023. P2Y12 inhibitors have to be administered prior to the percutaneous intervention with it has to be considered with a moderate level of evidence is what has been suggested. And with regards to dual antiplatelet therapy in 2017, the suggestion was that dual antiplatelet therapy has to be given for 3 to 6 months, and then after 6 months, aspirin could be stopped. So even in 2023, the sort of a strong evidence, when I say level A evidence, is a good level of evidence with, and what has to be considered is if patient is event free for 3 to 6 months on dual antiplatelet therapy, then they can be changed to single antiplatelet therapy with P2Y12 inhibitor has to be considered. So as you see, there is more emphasis on continuing P2Y12 inhibitor for a longer time as a single antiplatelet, and aspirin could be considered to be stopped at the end of 6 months. But there is a little bit of a debate because when I was giving this talk, maybe in Coimbatore, there was a cardiologist who believed that dual antiplatelets has to be given for 1 year. So that I think I would leave it to the experts, but the whole emphasis is more on continuation. GP2Y12 inhibitor has to be given for longer time is what has been suggested. So if patient comes with cardiac arrest, out of hospital cardiac arrest, and hemodynamically stable with no ECG changes, then the suggestion was that delayed sort of an angiographic evaluation has to be considered, was suggested in 2017. But this is important for intensivists. If it is out of hospital cardiac arrest with no evident ECG changes, then routine immediate angiographic evaluation is not recommended. So that should not, patient should not be subjected to the angiographic evaluation. If it's an out of hospital cardiac arrest, hemodynamically stable without ECG changes, it is not recommended. So this is something for intensivists, it may be useful because we get patients more like this with cardiac arrest. If patient is out of hospital cardiac arrest and patient remains comatose, so here 2017 suggested targeted temperature management or 32 to 36 degrees. This is also important for intensivists. It was suggested that 32 to 36 degree targeted temperature has to be maintained for 24 hours. In 2023, the strong recommendation with a moderate level of evidence is for only temperature control, not for targeted temperature management, where they suggest monitor core temperature and only fever has to be prevented. So there is a little de-emphasis on targeted temperature management in 2023, and this is recommended for both out-of-hospital cardiac arrest and intra-hospital cardiac arrest. And 2017, the suggestion was if your echocardiographic evaluation is inconclusive or suboptimal, alternate imaging like cardiac MRI should be considered, and that remains same even in 2023. There is a moderate recommendation, and it is with a weak level of evidence that cardiac MRI has to be thought of when your echo evaluation is suboptimal or inconclusive. So, and this is patient with the ECG changes before hospital discharge. So the suggestion in 2017 was even the non-infarct related artery, which means before the whole emphasis was only infarct related artery to be fixed or recanalized, but now the emphasis even the non-infarct related artery recanalization or percutaneous intervention of non-infarct related artery has to be considered. In 2023, strong recommendation with a good level of evidence is complete revascularization of the index percutaneous intervention has to happen within 45 days has to be recommended. So which means the whole focus is going more invasive, and recanalization or percutaneous intervention of the diseased vessels, if needs be, has to be accomplished is what has been recommended within 45 days of the event before hospital discharge has to be thought of. And 2017, there was a suggestion that blood sugar has to be less than 180, and that remains the same even in 2023. And most importantly, for all cardiac patients, the emphasis is on to avoid hypoglycemia, because hypoglycemia is more dangerous, that the risk of MI worsens and the morbidity and mortality is much higher if they have hypoglycemic episode, and that remains pretty much the same in 2023. So these are some of the new recommendations that have come in 2023. So the salient ones which may be of value to the intensivists. So now we'll quickly look into acute decompensated heart failure. What is new? So in acute decompensated heart failure can be divided into three categories. So one is heart failure with reduced ejection fraction, and the second one is heart failure with moderately reduced ejection fraction, which is they have divided into three categories, which is ejection fraction 41 to 50%, and heart failure with reduced ejection fraction, where you say ejection fraction is less than 50%. I think the first one is heart failure with preserved ejection fraction, where there is a good ejection fraction. And they have divided acute decompensated heart failure into no pulmonary edema, the one presenting with pulmonary edema or high output heart failure, and they put the fourth category as someone with right heart failure, and the fifth category as the cardiogenic shock. So these are the four categorization or stratification of heart failure they have done. And they've even suggested that generally the percentage of patients who get admitted with pulmonary edema is around 16%, out of which 3% have severe pulmonary edema, and most of these patients who come with severe pulmonary edema were found to have generally systolic blood pressure more than 180 millimeter mercury, and this is a typical X-ray feature of pulmonary edema. And they have divided into this sort of a checkerboard categorization of acute decompensated heart failure, where they put into four categories: warm and dry, warm and wet, cold and dry, cold and wet. The typical ones that we tend to see in ICU is these two, the warm and wet, which are predominantly heart failure with preserved ejection fraction, where they do not have cold peripheries, where they do not have too much of pulmonary edema or pedal edema, sorry, not pulmonary, pedal edema. Cold and wet is where they have cold peripheries and lot of pedal edema. So the warm and wet is typically seen in elderly people where there is lusiotropic effect or relaxation of the heart is affected. It is seen in more than 70% of older adults, and predominantly they present with pulmonary edema, and they have less of pedal edema, the warm and wet ones. The cold and wet occurs in less than 20% of the patients, and these are the patients with a low cardiac output, where the peripheries are cold and they have more pedal edema, and they come with more hemodynamic decompensation and cardiogenic shock. And these are the patients who are at an increased risk of death, and these are the patients who may need heart transplant at the end of 1 year, and they have a worse prognosis. So these are the typical categorization of the patients that we tend to see in ICU, and warm and dry is seen generally in less than 10%. So this is the sort of categorization of acute decompensated heart failure they have done. So for intensivists, just remember, increasingly we are seeing heart failures coming with a preserved ejection fraction, and that typically fits into the warm and wet. And the typical cold and wet cases you see more in CCU patients where they come with cardiogenic shock. Of course, we see in our ICU also. And you saw that 5 categorization of heart failure coming with pulmonary edema, coming with right heart failure, coming with cardiogenic shock, and preserved ejection, and moderately reduced and reduced. So this is something that is new categorization that has happened. So for all the trainees, the ADHF, if you can just keep this picture in your mind, this pretty much encapsulates the whole management principles of acute decompensated heart failure. So what are the key 4 pillars of acute decompensated heart failure? 4 pillars in management. The first one is MRA, which is mineralocorticoid receptor antagonist, like spironolactone, aldactone, eplerenone, so on and so forth. Then there is a new trial that has come on finerenone, which even showed good benefits. So MRA, mineralocorticoid receptor, are one of the important pillars of managing acute decompensated heart failure. The second pillar is beta blocker. Third pillar, which is a new kid on the block, is SGLT2 inhibitor. So this is something that has come as a recommendation from the American guidelines as a management tool for all the heart failure patients. The fourth category is angiotensin receptor neprilysin inhibitor. So ARNI inhibitors. So these are the 4 important pillars now for heart failure management. Of course, you have to put into the context of all other problems patient has. If patient has atrial fibrillation along with this, then you may have to put patients on anticoagulation, or digoxin also will be helpful in patients with heart failure presenting with EF. Or you may have to think of cardiac resynchronization therapy when there is a rhythm disturbance, and ivabradine could be considered to lower the heart rate. So this is in the additional setting of other additional problems, you may have to consider these drugs. And so, of course, if someone is in pulmonary edema, you would have to give loop diuretics and thiazides and diuretics to offload the lung. And in advanced heart failure, there is a suggestion for pulmonary vasodilators like Versagot or omecamtiv. And in advanced heart failure management, even all the ventricular assist devices like LVAD, RVAD, and other sort of a mechanical devices come into usage and should be considered. And any patients with advanced heart failure has to be listed at least for heart transplantation. And if someone has valvular lesions with severe regurgitant lesions, then surgical intervention has to be thought of. If someone has a VST, someone has severe MR, some severe AR, so surgical intervention to fix the regurgitant lesion to optimize the heart failure has to be thought of. And nitroglycerin or nitrates has to be considered in patients where you need to reduce the preload. You may have to think of nitrates, and arterial dilators, hydralazine to offload the LV has to be thought of. And if ARNI, angiotensin receptor neprilysin inhibitor, is something that can be a little pricey. So as an alternate, you can think of AC inhibitors or ARBs, which are more cost effective. And in patients where you have iron deficiency anemia with heart failure, with ferritin less than 100, transferrin less than 20%, you have to look at replenishing them with ferric carboxy maltose. So these are the different dimensions that you need to address in a patient with heart failure. So the main ones are the 4 T nuts I put in the rounds, and the additional problems that you may have has to be addressed with these other components that is been depicted. So now we just briefly talk about what the new kid on the block for heart failure is SGLT2 inhibitors. So the question is why this has come in. So very briefly, there is a separate video on only on SGLT. I'll just cover very briefly. What are SGLTs? It's very simple: sodium glucose transporter inhibitor. So that name itself tells you all your sodium and glucose gets absorbed in the proximal convoluted tubule. So the 90% of your glucose gets absorbed in the PCT. So this SGLT2 inhibitor, as the name sounds, sodium glucose transport. So they inhibit the absorption of glucose in the PCT, and glucose gets secreted in the urine. So basically, so that's a very simplified. So SGLT2 prevents the reabsorption of sodium and glucose, and they get secreted back into the urine. So your glucose levels in the body comes down, and since there is a sodium reabsorption that is not happening, so your sodium load also comes down, and that will help the heart failure patients. That's a simplistic mechanism. So basically, it acts on the renal proximal tubule, prevents the reabsorption of sodium and glucose gets secreted, and there is some sodium also reabsorption doesn't happen. So when you talk about SGLT, these are the drugs that are available currently in India. Dapagliflozin and empagliflozin are available. As you see, they're all approved in various countries. So the dosage of dapagliflozin is 10 mg once a day, and the dosage of empagliflozin is 10 mg once a day, and canagliflozin is 100 mg once a day. So the contraindications and precautions for these that has been described, these patients who's had a surgery, so these drugs have to be discontinued for 3 days prior to the surgery, and anyone with hypotension and hypovolemia, because it causes glycosuria and it prevents sodium reabsorption. So hypovolemia is a contraindication for these, and type 1 diabetes is a contraindication for using SGLT2 inhibitors, and previous DKA type 2 is a contraindication for SGLT2 inhibitors. And patients where estimated GFR is less than 30 ml per minute is a contraindication for SGLT2 inhibitors. And patients with UTI, because it causes glycosuria, there is glucose sitting in the urine, they are at a high risk for urinary tract infections. So that's why, especially ICU patients where the risk of UTI is high, these drugs have to be used with caution. So they cannot be recommended. So in fact, we have tried to use this in our heart failure. The suggestion from the cardiologist has been generally it's good that these are prescribed after the time of discharge from the hospital or from the ICU because of the risk of UTI. And even diabetic foot ulcers are contraindications for the use of these SGLT2 inhibitors. And there are good number of trials. There are at least some 8 to 10 trials. I'll just talk about, just for intensivists to remember the key trials. Emperor trial showed, Emperor reduced trial showed when they compared empagliflozin with the standard group, the risk of UTI was more in the empagliflozin. It was 1.7% versus 0.6%. And when you look at broadly the key articles, these are the two big studies that happened. DAPA heart failure study, where they used dapagliflozin, and Emperor reduced trial. Here they used the SGLT2 inhibitors in heart failure with reduced ejection fraction with or without diabetes, along with mineralocorticoid receptor antagonists and cardiac resynchronization therapy. Both these trials showed improvement in the clinical outcome, reduced all-cause mortality, and reduced worsening of heart failure across all NYHA classes from 2, 3, and 4. So there is a robust evidence indicating the benefits of SGLT2 inhibitor sheerly by preventing the sodium reabsorption and glucose reabsorption at the proximal convoluted tubule. It had an enormous beneficial effect in the heart failure. And canagliflozin in diabetic patient, it showed reduced hospital admissions in heart failure patients is what was shown. And because all these studies had such a very provocative, positive benefits in the trials that they conducted, so 2022, American Heart Association, American College of Cardiology, all these have incorporated the usage of SGLT2 in their guidelines. And dapagliflozin and empagliflozin 10 mg once daily has been put as a suggestion or recommendation in heart failure with reduced ejection fraction, and even in heart failure with moderately reduced ejection fraction, and heart failure with preserved ejection fraction. So this has been very strongly sort of has come as a recommendation in European and American guidelines. And we have put a mnemonic for this for all the heart failures. So it is A-cube BCDNS. So A is aspirin, MR, a mineral receptor antagonist, AC inhibitors, ARB, B is beta blockers, C is anticoagulation, D is diuretics, N is nitrates, and S is statins or SGLT2 inhibitors. So this is the easy mnemonic for all our intensivists to remember, especially when you have a heart failure, to try and put all the other dimensions that you need to put in place for optimizing heart failure. So this is a process issue that has been put in place by the cardiac intensivists, like how we have FASTag. These are all housekeeping measures in cardiac critical care, where they have put the checklist, what all has to be put in place, even in patients with cardiac intensive care, when you're dealing with heart failure or any of such condition in the cardiac setup. So they have emphasized on the putting infection control bundles in cardiac ICU, and to put measures to stop pain, and delirium assessment in CCU has been emphasized, and early NIV to be thought of in cardiac ICU has been emphasized, and uh, so spontaneous breathing trials and spontaneous awakening trials has been emphasized, and early mobilization has been increasingly emphasized with emphasis on physiotherapy and occupational therapy, and early mobilization has been emphasized in cardiac critical care, and early enteral nutrition has been emphasized in cardiac critical care with stress ulcer prophylaxis, and choice of sedation and analgesia to be thought of has been emphasized. And this is important. So I spoke about a trial that has come in 2024 about the role of IVC assessment and assessment of B lines in heart failure optimization. And this has come out. Even this has been recognized as a very important tool to look at focus as a tool to be incorporated in optimizing these cardiac critical care patients, and multidisciplinary approach to optimize the management and outcome in cardiac critical care has been emphasized. So this is more of administrative process issue, where housekeeping measures of various different dimensions to be put in place in cardiac ICU has been emphasized. So the last one or two slides is about this pyramid approach for risk stratification in cardiogenic shock has come from SCAI. SCAI is Society of Coronary Angiogram Intervention Society, Society of Coronary Angiography and Intervention. So they have categorized the cardiogenic shock patients that come to ICU into A, B, C, D, E. So A is, it is like a rifle criteria. It is as simple as rifle criteria. Identifying the patients at risk who may develop cardiogenic shock is A, where there are no signs and symptoms of cardiogenic shock or heart failure, and patients are hemodynamically stable. B is at risk. So A is at risk, B is beginning of hemodynamic instability, where blood pressure may be low, patient may be tachycardic, but there are no signs of tissue hypoxemia or hypoperfusion. So hypoperfusion has not set in. It's like a rifle criteria. So this is the patients you have to identify, pick them up, optimize heart failure so that they don't transit from B to C. C is classic cardiogenic shock, where they have hypoperfusion with hypotension, needing inotropes and needing balloon pumps. So really we would want to identify patients at A or B and prevent them from going to classic variant where they already develop hypoperfusion, lactates go up, then they may need inotropic support, vasopressors, and balloon pump. D is where deteriorating patient and where there is a cascading need of adjunctive supports and organ support means that they may be needing, and patient goes into full-fledged cardiogenic shock. Extremes is where patient is in a full-fledged cardiogenic shock, needing mechanical support, or VA, ECMO, so on and so forth. So this is just the categorization. Why they have categorized these? This categorization helps them to prognosticate and look at the mortality prediction. So what they have done is by stratifying the cardiogenic shock into A to E, they have determined that there is sequential increase in the mortality of these patients, both in hospital and long-term mortality. So if you look at A, who are at risk, long-term mortality is 24.9%, in hospital is 0.6. But when they go to the beginning, you see it, the long-term mortality is still the same, and in hospital is very less. Once they go to C, where there is a hypoperfusion setting in, there is a need for inotropes and balloon pump, which are typically the type of patients that come to ICU. You see the long-term mortality is 49.6. And D is where they have gone into cardiogenic shock. Your long-term mortality is 62.9, and extremes where they go on VA-ECMO or any other multi-organ support system, the mortality is 95.5%. So this is just to reflect upon different stages of cardiogenic shock, helping us to optimize the management better so that we can reduce the mortality and at least help us to counsel the patients with regards to the gravity of the situation and the concomitant morbidity and mortality. So that's about it, folks. So in cardiogenic, what's new in ACS? We spoke about what are the newest guidelines in ACS from 2023 guidelines. What has been more emphasized? The more emphasis on thinking more invasive and complete revascularization or percutaneous intervention of even the index vessels and non-infarct related artery has been emphasized. There's more emphasis on GPP2Y1 inhibitors as opposed to aspirin for 1 year to be continued. There has been more emphasis, and there is no immediate need for angiography after post-cardiac arrest. So there's no sort of a push towards doing it within 24 hours. So those are some of the changes. And with regards to heart failure, what's new? We saw the categorization of heart failure as moderately reduced, preserved, and reduced ejection fraction. And you saw that 4 compartments, what they have looked at, and all the treatment dimensions that I showed pictorially. And more emphasis on SGLT2 inhibitors in most guidelines has been incorporated. And the third thing we saw is the categorization of the cardiogenic shock. So this is all I could find about what are the new things that have been evolving in cardiac circles. So I request you all to submit your valuable work to Journal of Acute Care. So you can visit my website to refer to this lecture. So thank you. Thank you, Manindra.